Well, welcome back to the podcast, Dr. Thompson. I'm excited to have you back. We had you on first talking about the Da Vinci robotic surgery, but today's topic is a little bit different. So if you missed that episode, definitely go check that out. You can learn a little bit more about Dr. Thompson as well. But today I'm excited to talk a little bit about colonoscopies and endoscopies and kind of what the differences are. So do you kind of want to start there?
Yeah, thanks for having me again. I'll kind of explain a little bit. So endoscopy itself is literally the thought process of having like a long tube with a light and a camera on the end of it. So colonoscopy is a form of endoscopy. We call it like a lower endoscopy because it's going through the backside for your colon. There's also what we call upper endoscopy, or another word for that is EGD. So patients might hear one of those two. And that's where they go through and look at the upper portion. So the esophagus, the stomach, and the first part of your small intestine. So upper endoscopy and lower endoscopy are kind of the same thing, but different areas.
Yeah. And I think, many people might not understand or know that general surgeons can also do the procedures of colonoscopies and endoscopies.
Yeah.
Talk a little bit about kind of what that is. It extra training, or what was that process like for you as you were going through school to kind of be able to then also offer this here at Coleman Regional?
Yeah. So endoscopy has actually been a part of surgical training for the length of since endoscopy has been invented. So endoscopy is something that's required by every general surgeon in their residency program to get a certain amount of upper and lower endoscopies to be checked off and to be trained on those as well, because in smaller towns and more rural areas and stuff, they do all of those. And so you get to your bigger cities where there's a lot of gastroenterologists and stuff as well. So they kind of take over that specialty more so at that point in time. But in other areas where we don't have as many gastroenterologists and stuff, surgeons still do all of that themselves. So it's something that I love to do. Most general surgeons do love to do it as well. That not a lot of them get to continue doing it after residency just because of where they end up training at, if they're in a larger city or something of the sort. But majority of general surgeons love to do that, and colorectal surgeons, because a big part of that is you're getting to see the pathology yourself. Because if you go to a gastroenterologist and they find they do your procedure, they find something that needs to be fixed surgically, they're going to send you to a surgeon next. And then that surgeon's going to want to go see it himself as well, usually, to determine what needs to be done exactly. So a lot of times you're getting the same procedure twice. If it's a cancer that needs to be taken out, they're going to want to see it themselves a lot of times with their own eyes, where it was at. A lot of times we trust the gastroenterologist to pick it out and stuff and show us where it is. But a lot of people want to go back and see exactly what they're talking about. So you could end up going through the same procedure twice a lot of times to get it done.
Yeah. And so talk a little bit about some of the conditions or symptoms that are related with both a colonoscopy and endoscopy.
So what I'll say about colonoscopies, I'll kind of go on a harp real quick about that. Colonoscopy screening is huge. It's something everybody needs to be getting done on a regular basis. The new age is 45 years old. It used to be 50. There's a lot of there's a mantra of being scared about getting a colonoscopy. I don't want to have a colonoscopy myself. The prep that everybody talked about back in the day is we don't have those terrible preps anymore. So not nearly as bad as people make them out to be. So we have a lot of different preps we can do as well that patients tolerate a lot more. And so we're really trying to make a push to get everybody getting regular screens, because 80% is what the national average of what they want the population getting screened at their regular dates of 45 or 50 or 55. And I think Coleman's about 71 right now. So we're trying to get to that point, but it's something that we're trying to get everybody to know about, because it's not nearly as bad as what people think. And it's something that literally can save your life. Colon cancer is what we're screening for, colon cancer and colon polyps. Colon cancer is the third most common cancer in men and women, second most common leading cause of death of cancers in men and women. So this is literally a pathology or a disease that you can stop in its tracks just by simply giving 30 minutes of your day to do a colonoscopy. And then the whole idea is that we go in there, we're trying to find polyps before they become cancers. So yes, we find cancers also, but we're trying to find them before they become cancers, so that we can take that polyp out at that time during the colonoscopy, and then you're done. That polyp's natural progression to a cancer is now gone, and you're starting over at zero, and there's nothing else to do at that point in time but surveillance again. Whereas if we're catching things as cancers later on, that's now requiring a surgical procedure to cut that portion of the colon out. So we want to do things before that happens. And so time and time again, we have patients come in that are 55 or 60 and they still haven't had a colonoscopy for whatever reason. They were scared, or a family member said something about it, what it may have been, and they finally have it done, and then we find a cancer at that point in time. Well, had they done it at the normal scheduled age of 45 or 50, that would have been a polyp at that point in time. And we would have not been doing a colon resection. We would have just taken that polyp out and they would have been done.
Wow.
So it's really just letting the public know that this is something that is a basic screening thing that can literally save your life if you just give your time up for it.
Yeah. And so with the colonoscopy, is there sort of like, as the patients begin that, 45, 50, they start doing their checkups, is it in every 3 years and every 5 year kind of thing? Or is it every patient's kind of, it depends on the patient itself?
It does. So there's a couple of different things. So like I said, like you're right, the new screening age is 45, not 50, because they're catching colon cancers in early ages now. And then also, if you have a family history and a close relative of a mother or father of the sort that had colon cancer, it kind of dictates a little bit as well. But after you have your colonoscopy, if we find a polyp, depending on what type of polyp it is as well, or how many polyps or the size of the polyp, will dictate if you need one in 3 years, 5 years, or usually 10 years.
Wow.
So it's one of those three usually. Sometimes it's a little sooner, but usually it's one of those three.
Yeah. And so you talked a little bit earlier about the prep and how the prep's completely changed, and you sort of the idea of someone's listening that maybe is pushed off that colonoscopy because of what the prep used to be. What is that typical prep? You kind of alluded to it a little bit earlier, but what's the typical prep that you recommend to most of your patients?
Yeah, so there's two main ones that we use, but one involves Miralax and some Dulcolax tablets and a bunch of water or Gatorade, and the other one is a bunch of tablets. If someone doesn't like to take all that, they can do a tablet prep where they take about 20 or so tablets in the course with some water or Gatorade as well, and it's over the course of 4 to 8 hours, and then basically you spend an afternoon doing the prep for the next morning for the procedure. But those are the main two. But the old times of people having to have a giant gallons of what we call Go Lightly and these things that are just terrible to drink, I wouldn't recommend it for anybody. But patients had to go through that and stuff.
Wow.
We don't really do that one anymore.
Yeah, and so we talked a little bit earlier, but just that general surgeons can also do the stuff with the colonoscopies and everything. Is there any advantages to having a general surgeon do it over a gastroenterologist?
They all should be able to, the detection rate for polyps or cancers and stuff should be pretty equivalent between the two of them. So they should catch anything that's in there, despite who it is. But at the same time, knowing that the surgeon's going to be the one that would do the surgery afterwards, if they do find a cancer or whatnot, it's good for him to know exactly what he's looking at and have an idea where it's at in the abdomen for when they go in there and actually have to take that portion out, versus having never seen the patient beforehand, not having done that portion of the case with the patient, and then seeing them afterwards and taking somebody who's been sent to you saying, I have this problem. We marked it here. Well, sometimes it's not always exact and stuff. So it's better to know if the surgeon who's going to be doing the surgery has seen everything himself beforehand.
Yeah, and so as someone's listening and they finally decide it's time for them to actually schedule that appointment, what does that process look like, and how quickly can a patient get into either a general surgeon or a gastroenterologist or whatever it might be to actually get that appointment and schedule that colonoscopy? Yeah.
So with our all three of my partners and I do colonoscopies and upper endoscopies as well. So anytime that they want to have it done, we can usually get them into the office to be seen within the week with one of the four of us, and then usually can get you scheduled to have either one of those procedures done within the next week or two for sure.
Yeah.
By one of the four of us. No, that shouldn't be an issue at all. I know sometimes it can take weeks and months at certain places and stuff, but here we can get you in very quickly and get you seen and get you turned around to have the procedure done very quickly.
Yeah. And so we talked a little bit about the process for a patient to go through that and the prep on the front end of what they do prior to coming in for the colonoscopy or the endoscopy or whatever it might be. What does sort of that follow up look like for the patient, and how quickly is everything back to normal for them? Yeah.
So what it is, you'll come in, you'll do the prep the day before, then you come in for the procedure usually about an hour before your procedure is scheduled. So if it's 9 a.m., you'll come in at 8 a.m. to the hospital. They'll get you set up, they'll give you an IV. You'll come back into the GI lab room where they'll give you some sedation. It's just some light sedation where you basically have a 20-minute nap. You don't remember anything for that 20 minutes. It takes about 20 to 30 minutes to do a colonoscopy. For an upper endoscopy, it takes about 5 to 10 minutes.
Wow.
And so it's very quick. And then they have great prep. We're able to see the entire colon. We take out any polyps we see during that. And then what it is a family member or a friend or close relative, anything like that, who comes with you, they'll take you home afterwards. You usually spend about 20 to 40 minutes in recovery, waking up. Then they take you home afterwards. We'll go out and speak with you or the family member, let them know what we found and whatnot. And then what we'll do is we'll have you come back and see us in the clinic so we can go over everything again and with the pathology at that point in time, because we send off the polyps to see what type of polyps they are. It takes a couple of days for that to get back, and then we can go over all that with them at that point.
Gotcha. And so you talked a little bit about that time for the actual surgery is both are pretty short. On a typical sort of day that you're doing colonoscopies or upper endoscopies, how many are you typically doing, or like what does that look like for your workload as you're meeting with patients and doing all these steps with them and performing the surgeries? Yeah.
So, for me, I do mine on Monday mornings. So all morning long from 7 a.m. until about 1 p.m., I'll be doing upper and lower endoscopies. Just we go room to room, back and forth like that. And so we'll do 10 to 15 in a morning.
Wow.
Is on average usually.
So what advanced technologies or techniques do the general surgeons here use for endoscopies and colonoscopies that patients might find beneficial?
So it's pretty much the same as anywhere else you'd have it. So we have the ability to remove small and large polyps. There's different ways to do that depending on what type of polyp it is, how big it is and whatnot. And then, the way you can do it if you have a cancer or something you're concerned of also, where we have the ability to tattoo the colon so that if we do have to go back in, God forbid, and take a portion of your colon out for a cancer later on, we're able to see it intraoperatively where that spot was exactly on your colon wall, because we were able to literally tattoo the colon with ink like you would have tattoo on your arm and stuff. So those things help. And then the same thing goes for upper endoscopy. So looking at the esophagus and the stomach, if we're working you up for severe reflux and you might need a reflux procedure done, we're able to see exactly what is going on with the stomach. We're able to check and see how bad the acid reflux is with different machines and stuff as well. So those little things we have all here as well.
So one thing I think that we alluded to a little bit earlier was just some of the signs and symptoms or that might lead people to then schedule their colonoscopies or endoscopies. Talk a little bit about what that looks like for patients.
Yeah. So that's the big one about colonoscopies is for screens and whatnot, is colon cancer can happen and then it doesn't show signs. So that's why you've got to get the screenings done at the appropriate ages, because a lot of times colonoscopies have zero signs. It's a healthy person, has had no issues at all, has no family history of colon cancer. And then bam, they have this pop up out of nowhere. But bleeding per rectum, that's one. Abdominal pains, change in bowel habits or changes in the size and consistency of your stool. All those things can lead someone to get a colonoscopy sooner than the recommended time frame if those things persist. That's the case for colonoscopies. For lower endoscopies. For upper endoscopies, it's a little different as well. Acid reflux or heartburn consistently, upper abdominal pains, difficulty swallowing, foods feeling like they're getting caught, those sorts of things, those would lead you to have an upper endoscopy as well.
So since we just talked a little bit about some of the symptoms and some of the things to look for that would lead someone to schedule or have a colonoscopy or upper endoscopy, talk a little bit about your thoughts on the alternative what
screening options.
Okay. So since we just talked a little bit about the symptoms and some of the things to look for that would lead patients to schedule colonoscopy or upper endoscopy, talk a little bit about your thoughts on the alternative screening options for colonoscopies.
Yeah. So the big one is the stool test. So everybody probably hears it as what's called Cologuard. And that's something that's gotten a lot of people are being referred to do that instead. A lot of times that don't want to do colonoscopies. And I do want to caution on that because the idea behind the Cologuard, if nobody knows, it's basically a stool test where you submit some stool to this and you send it off and they come back and they say positive or negative. And so what that stool test is checking for is blood in your stool and then also about 11 different DNA biomarkers. So what that's looking for is cancer. Okay, so it markets itself as being 92% successful at detecting colon cancers. Well, that's great. Now that you had a positive Cologuard, now you go get a colonoscopy, they find a cancer. So it did its job. It found the colon cancer, but now you have a cancer. Okay, whereas if you did the colonoscopy when you're supposed to, it would have been a polyp at that point in time, and you're not getting a colon resection. You're just getting that polyp removed during the colonoscopy, and you're done. So this 92% detection rate for a colon cancer is finding cancers, not polyps. Its chances of finding a polyp are about 40%. So it's much different in regards to that. It also has about an 8%. Let's see. start that again. But is it 13? It's 8% false negative rate and 13% false. Okay. So it also has an 8% false negative rate, meaning you had a negative Cologuard, but you do actually have a cancer or a precancerous polyp. And it has a 13% false positive rate, meaning you do the Cologuard test, you have nothing going on in your colon, but it still gives you a positive anyway. So then you have to have a colonoscopy anyways. So there's a lot that comes around through that. And people get a negative reassurance because you had a negative Cologuard test. So you're like, I'm good. I don't have colon cancer or anything like that. And they go about their lives thinking they're perfectly fine, where they might have a 3 centimeter large precancerous polyp just sitting there about to become a colon cancer. And if they would have had the colonoscopy done like they're supposed to at their scheduled times, we've gotten that out and it wouldn't be an issue at all. So it's something that I think gives a false reassurance to a lot of patients that think that they had a negative Cologuard, therefore they're good to go. And that's not the case with those things. They're finding cancers, not polyps.
Awesome. Well, thank you again for taking the time today to talk a little bit about colonoscopies and upper endoscopies and kind of the treatment processes, the symptoms, and kind of things to look for and avoid. I think everyone that listening, and myself included, learned a lot about kind of this. And I hope people that are maybe on the fence of, do I schedule that appointment or do I not? Hopefully they kind of push their way into scheduling that appointment with you and getting that checkup. So thank you so much for being here.
Thank you. Appreciate it.